So yes, like Dr. Joshi mentioned, I'm going to speak about heart disease in Asian Indians and South Asians in more general in the United States, and some practical lessons we've learned from doing this study called the Masala study. So why and what was the aims of doing the Masala study? And it was really to establish a prospective community-based cohort of South Asians in the US to understand what are traditional factors, sociocultural factors, behaviors, and other novel risk factors that are associated with hardening of the arteries, or this thing called subclinical atherosclerosis, which is a precursor that leads to heart disease, and compare the differences in our cardiovascular risks to other groups in a study that's our sister study called the MESA study. I'll show you a little more information soon about that. And the long-term goal is to investigate what factors are associated with South Asians developing cardiovascular disease. So the way we designed Masala was based on one grant that we received from the NIH. We had enough money to enroll 900 people. We chose to go include people between age 40 and 84, and they could not already have existing cardiovascular disease. So we were careful to exclude people who already had had a heart attack or had had stents placed or had had a stroke, because we're looking at factors that lead to these diseases, so we can't also already have people who have those diseases. And only South Asians, but we were very broad in this definition of South Asian. So anyone with 3 grandparents who were born anywhere on the South Asian peninsula could have been included in this study. And we recruited people from 2 sites, my site in San Francisco, and my companion site is at Northwestern University in Chicago. We did a pilot study, and we did the baseline study with this 900 person group starting in 2010, and we brought everyone back and again finished a second exam in 2018. And we're partnered with a larger study in the US called the Multi-Ethnic Study of Atherosclerosis, or MESA, and they have a slightly older group of 45 to 84. We were 40 to 84, and we went a little younger on purpose in Masala because we know that Asian Indians and South Asians develop heart disease and diabetes and other risk factors at earlier ages. So we're trying to capture that. They had a lot more money for this study from the NIH, so they had 6,500 people. And again, we had similar methods. We excluded people with existing cardiovascular disease because we want to understand what leads to cardiovascular disease. They have 4 different race ethnic groups in MESA: whites, blacks, Latinos, and Chinese Americans. So it's a great study for us to partner with so we can compare the South Asians to these 4 groups. They have 6 centers around the US, one in New York City, one in Maryland, Baltimore, one in Chicago, so that's our same Northwestern University site, one in Minnesota, one in Los Angeles, and one in North Carolina. So they started 10 years before Masala, but we're able to compare what they were finding to what we were finding. So here's what we have accomplished so far in terms of all of the visits we've had with our 900 participants. This is the first exam when we brought them in and did fasting blood tests, but we also did a glucose tolerance test. Now, this is not a test that you do routinely with your doctor unless you're a pregnant woman. Pregnant women do glucose tolerance tests, but in general, we don't do this for most patients in clinical practice because it is time consuming and a little bit inconvenient for people to do. But in the research study, I think it's really important for us because it tells us about who is at high risk of developing diabetes. We also did a CT scan of the heart to look at atherosclerosis, so hardening of the artery, who has calcium deposits or plaques in their heart arteries already. We looked at their ultrasound of their neck to look at hardening of the artery that goes to the brain, and we did an EKG. We brought people back again a few years later to look at their social networks. I'll show you some of the interesting data we've learned about who people have in their social networks and what the social networks can bring to improve health. And then we brought everyone back in 2016, and we did a repeat set of blood tests, glucose tolerance test, and CT scans, and we were able to include 258 new participants. So, this was a really big endeavor. So we have a total of over 1,150 surviving participants who we continue to follow. And I'm hopeful that we get new funding from the NIH at the end of this year so we can bring everyone back to do new different tests on their heart. The goal is to understand what causes heart disease, and it will take time to accumulate numbers of people who, as they develop heart disease, to see what the factors were. So who are these people who are in Masala? 98% of our participants in the study are immigrants to the United States. And of course you understand why, because we're looking at age group 40 to 84, and most of these people have immigrated here. Very few people in the 40s were actually born here. So 2% are second generation, are kids who've grown up here. And most of our population comes from India. 83% were born in India, about 2/3 from North India and 1/3 from South India. And you can see 6% from Pakistan, 1% from the other South Asian countries, and there's other diaspora countries as well that people have immigrated from. So the amount of time that people have spent in the US is about half of their life, or 28 years of their life had been in the US, or about 50%. And you can see a nice normal distribution. This is shows that there's some people who've been in the US only for a few years, 0 to 10 years, but some people like my parents have been here 45 years, and I immigrated here myself when I was 6 years old. So what about socioeconomic status of people in the study? And this is very parallel to what we know in the census data, that South Asians, and again, this being 83% Asian Indians in our study, they're very highly educated, because this is the immigration laws that we're used to, that the reason people were allowed to immigrate to the US in 1965 is they were coming with for higher education, or they were professionals already. So the men and women, 64% of men and 47% of women had higher than a bachelor's degree, so had done some graduate school work or had a professional degree. And you can see another, quarter to a third had a bachelor's degree. So much, much higher than other groups in our sister study, MESA. And similarly, as you would expect, family income is also quite high in the greater than 100,000 group for most of the people in this study. So we understand that South Asians in the US are, the most wealthy, affluent, and as well as most educated race ethnic group, and that is something that our study is also showing. So what about that? There's these wealthy people, and you would think that they would have, very little problems with their health, but we found that about 26% of people have diabetes, and another third have pre-diabetes, and 40% are normal. Now, how does that compare with other people? And so this is where I think our partnership with MESA has been really very, strong and illuminating, because when we compare the South Asians here, and here I'm taking out the people who are between 40 and 45 years old, because we want to compare apples to apples with the MESA group. And what I want you to focus on is this fully adjusted row here at the bottom. This shows that in South Asians, after we adjust for differences in age, in sex, in education, income, smoking, alcohol, exercise, body mass index, waist circumference, and lots of other risk factors that can be associated with diabetes, the South Asians had almost 27% diabetes, whites had 6%, African Americans 16%, Latinos 14%, Chinese 16%. So the South Asian group is much higher in diabetes, and again, most educated as well as most affluent group, but it's still not preventing the diabetes. What about the lifestyle and behaviors, and are some of these the reason why there's so much diabetes? So we're looking here again, South Asian in the first column, and the 4 other groups we're comparing to. Smoking has been associated with higher risk of diabetes, but our South Asians in the study are not current smokers. And I think you can see even the Chinese in MESA were not likely to smoke. The other 3 groups were much higher prevalence of smoking. Alcohol has also been associated with diabetes, but again, South Asians were very moderate drinkers, and Chinese even less. Chinese were drinking, more than one drink a week, which is very low. And then you can see the other three groups were drinking much more than that. But exercise, now this is a very modifiable risk factor. People who have resources, people who have money, people who have education, people who know other people in their family who have diabetes, exercise was the worst in the South Asian groups, and that's quite embarrassing, because the way we measure exercise was the same as in the other groups, but it was using a questionnaire that asked, how many minutes do you walk in the day or in the week? How many times do you do yoga? How many times do you do other aerobic exercise, weightlifting, anything? Even, doing things like just random activities around the house. So we're using the same questionnaire, and it was really very low in South Asian. So tells us that there's something that definitely we need to be doing better. How about diet? Now, I know you're going to have a whole talk about diet with Ashwini Wagle next month, and I've given talks with her, so this is a good intro to what she'll be also talking to you about. We spent a lot of time and energy in measuring South Asian foods. We asked a long questionnaire with 163 items that took 45 minutes to ask people what types of foods they eat routinely. We asked a lot about Indian foods, South Asian foods, continental foods, US foods, all different types of diets. And then we use this data to look at what dietary patterns are people eating. And you can see, it's really hard to measure South Asian food because it varies from country to country, from state to state, from region to region. There's so much variability. So this is a real conundrum. How do you measure South Asian diet? And what we found when we put all this data together is that people eat mainly three different types of dietary patterns. And about a third of our participants were eating a diet that was high in animal protein, and a third were eating a diet that was high in fried snacks, sweets, and high-fat dairy. A lot of you will find lots of familiar-looking snacks and desserts here. And a third were eating a diet that was high in fruits, vegetables, nuts, and legumes like lentils and beans. And so these three diets were the main diet. That doesn't mean that if a person is eating this type of diet, that's all they eat. Some days when they go to parties or weddings, they may be eating this. Some days maybe they'll eat a little meat. But on the average, most people were eating, one of these diets more frequently. So we looked at these diets and what does that mean for health? And we found that people eating this animal protein diet and the people eating this middle, more traditional South Asian diet had much higher weight, bigger waist circumferences, bigger belly fat, higher blood pressure, and lower HDL cholesterol. And these are all metabolically, these are risk factors that can lead to heart disease. And so the big take home here is that, we can move to diets like this. This is potentially a very modifiable risk factors. We should try to eat more of these kind of fruits, vegetables, nuts, and legumes on a regular basis. So we looked at this a little bit more carefully because, when we look at the people who are in this middle group, fried snacks, sweets, and high-fat dairy, half of the people here were vegetarian. And we looked at this group here, the fruits, vegetables, nuts, legumes group, half were vegetarian. So some were eating fish and chicken and other things in both of these groups. But this was predominantly the main things they were eating. And what we wanted to look at was vegetarianism. Like, what is it about, eating plant-based foods? We know that there are healthy forms of plant-based foods and less healthy. So the healthy was what I showed in that picture: whole grains, fruits, vegetables, herbs, spices, nuts, legumes. And less healthy are refined grains, so the flour that has been really, really finely ground, fruit juices, potatoes, and other, root vegetables that are more starchy. deep fried snacks, coconut, sweets and desserts, and sweetened beverages. So when we looked and we put people into categories like how much healthy plant-based foods are they eating and how much unhealthy, and then we looked at what happened to them in the future, what we found was people who were eating the healthy in green, healthy plant-based diet, they had less risk of having a fatty liver. And a fatty liver is something that can lead to diabetes, even lead to heart disease. And they were less likely to develop diabetes in the 5 years when we saw them in the future. So below the line of 1 shows that they're less likely to develop, fatty liver and diabetes. The people eating more of this unhealthy or less healthy plant-based foods, are in red, and you can see that there is a higher risk of developing diabetes as well as a little bit higher of fatty liver. So not only is it about, eating plant-based foods, but really choosing the healthier types of plant-based foods. And this is a good, dietary information. So let's talk about weight. This is always kind of a big, question mark for us. We know that the WHO, World Health Organization, has certain criteria for underweight, normal, overweight, and obese, and this is called body mass index. And this is a ratio of your weight divided by your height, and it's in metric units. So we know that for most people, we use these, cutoffs of 25 is overweight and 30 is obese. But the WHO has recommended lower cut points for Asians, including Asian Indians, that we should use 23 for overweight and 27.5 for obese. And that's because our body frames are smaller and we tend to have, more problems even with lower body weight. And so we wanted to really understand that is there more problems with lower body weight? And so when we look at our Masala participants and we compare them to the other 4 groups in MESA, the left panel here shows you people in the normal weight. So for Asian Indians, that would be a BMI less than 23, normal BMI. And for the other groups, it's less than 25. Chinese, it's also less than 23 because they're Asian. So here it shows you the prevalence is about 25%. The South Asians are in red, which shows me that they're kind of in the middle here of the other groups where, having about average amounts of people who are normal weight, but also having average amounts of people who are overweight as well as obese, kind of right in the middle. So, it's not true that we don't have obesity in Indians. We definitely do have obesity if we use the right term of 27.5. But, there's plenty of overweight, but there's also people, who are normal weight. So we wanted to drill down into this normal weight group to say, well, the normal weight people should be fine. They should be okay. They should have no problems with diabetes or heart disease. Is that true? But what we found is if we look at just the normal weight here on the left, the red dots show you who has metabolic abnormalities. That means high blood pressure, high glucose, or bad cholesterol. And what we found was in South Asians, even in the normal weight category, there was a lot more metabolic abnormalities, the blue being normal, no metabolic abnormalities. And you can see the red dot is much higher for South Asians compared to the other groups. And in fact, if we say, well, then if our BMI, even normal BMI, doesn't mean like we're, doing that great, then what kind of BMI is normal? Like what BMI should we be aspiring to if weight is really important for having, future problems? And when we look at this is a kind of a complicated curve, but I want to explain it to you. So if you look at the dashed line here, this is for whites. And for whites, the average amount of metabolic abnormalities at a BMI of 25 when they're just starting to be overweight is about 30%. But what is the equivalent BMI when South Asians start to have metabolic abnormalities? Turns out that 19.6 is what it is. So I'm not saying that we should aspire to getting a BMI less than 19.6, but that is when we start to see metabolic abnormalities happen. And perhaps this is telling us that, any extra weight that is on our bodies is tending to do more harm, and it's worse off for us and our health than for other groups. And we've kind of known about this because these two gentlemen, this was studied back in 2004, they're scientists. John Yudkin is from England, and he has a BMI that's normal, 22.3. And then this is Ranjan Yajnik, who is from Pune. He's a professor in India, and his BMI is identical, 22.3. But when you do a DEXA scan, which is a scan that looks at bone density, but also looks at fat volume, the fat amount for the European man is 9%. But for the same BMI, the Indian man has 21%. So there's something going on, maybe in our genetics, that's causing us to have more fat, even in the normal BMI range. And so we spent a lot of time trying to understand this by looking at all these hidden fat stores, like where is the fat going? Is the fat in the muscle? Is the fat in the liver? Is the fat around our abdomen organs called visceral fat, or around the heart? And we measured these areas with CT scans. And what I'm showing you here is a cross section. It's like one cut through the abdomen, like a bread loaf, and we were taking these CT scan cuts, and we use software to look at where the fat is. So the green shows you fat underneath the skin. This is the fat you can pinch with your fingers. And then the light blue shows you fat around the intestines. You can see the dark blue showing gas in the intestines, and the light blue is the fat around the intestines. This is muscle in the back here, and this is showing light blue, showing you fat in the muscle. And here's a picture of the liver. We can't use this kind of software to look at area of fat in the liver, but we can look at attenuation of fat, how dense the liver is, and the less dense it is means there's more fat. So we use these CT scans to look at fat and compared it to MESA. And what we found was the South Asians are storing fat in all of the wrong places. So here in yellow, South Asians, visceral fat is fat around the abdomen organs. South Asians had higher levels of visceral fat compared to the other groups. They had more fat in the muscle compared to other groups. More fat in the liver. This is showing less attenuation, so that means more fat in the liver compared to the other four groups, and less lean mass. That means less muscle mass because there's more fat in the body. So having a normal BMI does not mean that there's no risk, because there's this excess fat in all of the wrong places. And having fat in these places is detrimental because it can lead to diabetes and heart disease. So let's move to a few other concepts that we've learned about. And one is acculturation. You've heard of like the melting pot analogy. I like to think of it more like a quilt, that each culture in the US is bringing different things that we can add to this quilt of what America is, very multicultural. And so we collected a lot of items in Masala when we asked these questions about how long people have lived in the US, because we know the longer you live, the more you tend to acculturate to the dominant culture. How proficient English language is, people who speak more English are more acculturated. What types of food are eaten at home or outside the home, how frequently are people doing social, cultural, religious gatherings. Of course, this is pre-COVID, things have changed this year. How frequently are people shopping at South Asian markets? Who are their friends? Who are they associating with? And what about traditional cultural beliefs? And so we, again, just like we did with the food questionnaires, we did the same thing with these questions where we put it all together. Like, what does all of this data mean? And what we did was we were able to group people into 3 different buckets. And one was how acculturated they are. So here in the orange part of the semicircle, this is people who are not very acculturated. They have retained more of the South Asian traditional, cultural values and beliefs, and they're called a separation class. They kind of stay separate from the US dominant culture here. And then there is this middle group that has both. It's become more bicultural. So it's an integration class taking in South Asian beliefs and values as well as some from the US. And then in the purple is people who have mostly Western or American beliefs, and this is called the assimilation. So they are really assimilated to the US and have not retained many of the South Asian beliefs. You can see half of our participants were in this bicultural group, and about a quarter and a quarter were in the other two groups. So what does this mean for health about how you have assimilated or acculturated? And what we found was people in this orange half moon separation class had more depression. And that you can understand why. Maybe they feel more separated, they feel more isolated and not, as involved with what's going on around them in their neighborhoods or in their cities or towns. Um, but what we found here was really interesting, that people actually in the assimilation class who have, really adopted American culture, and also the bicultural group had lower cardiometabolic risk. This is fascinating to me because that tells me that people may be adopting behaviors that are healthier than what is going on, in our traditional culture. So what could those behaviors be? Diet, exercise, stress, other things about, how we live our lives that may be not so healthy. And this is also stands in contrast with other immigrant groups. So when people have done this type of, acculturation analysis of Japanese immigrants or Mexican immigrants to the US, they found totally different things. They found that people who stay separated and do not integrate or assimilate have less risk factors. They have less diabetes, less obesity, less heart disease. We're finding the opposite. So that just tells me there's something culturally maybe not so beneficial for our health. So what about social networks? I told you we started collecting some of the social networks data to understand our health. And we asked people who is, if they're in the middle, they're the ego, who are the people who are in their social networks the most, their tightest members, and they could be family or friends. Who do they talk to most often? And what we found was that the people who have the highest influence on our participants are their adult children. They're the influencers. 70% of our participants describe their older adult children as role models for healthy behaviors. That the adult children who are eating uncooked vegetables and fresh fruit daily, like salad and those fresh leafy vegetables, they're the ones whose parents have better diet quality. They're eating better because their kids are eating better. And the adult children who are exercising, those parents were also exercising. They were meeting the physical activity guidelines compared to the parents who didn't have adult children who were doing this. So this is really important because when we start to want to work with people to have people adopt healthy behaviors, is if the kids are doing it, then the parents are going to more likely start doing it too. And we also looked at friends and spouses, like how about behaviors of your own peers? And what we found for men is that when the men exercise with a exercise partner who's not their spouse, so another friend, they exercise a lot more. But for women, when they exercise with their spouses, they exercise more. So something about the spousal pair being somewhat more influencing women, but having a non-spouse partner to exercise with was more motivating for men. So maybe because the men are exercising with both, their spouse and with a partner, that's even better. So let me end by showing you some of this coronary artery calcium data that I mentioned. Now this is another CT scan of the heart. It's a cross section through the heart. This is the left ventricle, and then these are the two smaller atria. The white is showing you calcium deposits in the arteries of the heart. And we can score this and give something called a coronary artery calcium score. And what this is showing is in this schematic is as we develop in time, as we age, that there are plaques that form in, this is a cross section of an artery. And what happens is as the plaque forms on the artery wall, the body wants to put calcium to calcify the plaque or to stabilize the plaque, because the body doesn't want this plaque, this foreign thing that's happening to the vessel wall, it doesn't want it to rupture. But over time, that plaque can become vulnerable and it can rupture. And when it ruptures and all this, fatty material from the plaque goes into the bloodstream, the blood is flowing through the middle of this artery, the platelets and other blood cells stick on that ruptured plaque and cause a clot to form. And that process of having a clot form, preventing blood flow through the artery, is what causes a heart attack. So when we measure calcium, we're measuring over here, way before a heart attack, but it tells us who is more likely to develop a heart attack. And my hypothesis when we did this is we're going to find a lot of plaque in South Asians, even before they develop heart attacks. And we did see that, especially in the men. So here's our South Asian men in red and the other groups in Mesa. And this is between age 40 and 80. This is showing you the CAC score. So higher being more calcium in the arteries. The South Asians and the whites were very similar. They had very high levels of CAC, especially after age 60. The women were somewhat different. The white women had a little bit higher scores, but you can see the scale is different. Women have a lot less of this plaque than men. Even in the age of 80, the average CAC is about 40, 50, whereas for men at the age of 80, the average CAC can be 200 or 100, 200, depending on the ethnic group. So there is a lot of CAC, and we are looking at whether CAC itself will predict who ends up having a heart attack in our study now. So I'm going to end here giving you a summary and having a lot of time for questions. South Asians do have higher rates of diabetes, and maybe the body fat, especially the body fat in all the wrong places, that may be partially the problem. Get screened for risk factors. By that I mean check your glucose levels, cholesterol levels, and blood pressure, regardless of BMI. So if your BMI is low, that doesn't mean it protects you. There are several modifiable risk factors. And this is like the big, take home message, is that this is very, I think, a positive way to look at this, is that there are things you can do in your control, like a prudent dietary pattern, healthy plant-based diet, very, very important. Exercise, we are really very low as a whole, group of people in the US. We can do better with exercise. And by that, I mean walking, simple walking. Um, Moderate traditional cultural beliefs, or people in that, bicultural integration strategies, maybe taking the best from both cultures seems to be better for health. I didn't show you some of the data on anxiety and stress, but we definitely have seen that people with higher levels of stress, depression, anxiety have more uh, thickening of the arteries. And the most important is the adult children in terms of making lifestyle changes, as they can be the influencers. I think CAC is going to be a very important risk factor, especially in South Asians. And I do recommend that people who don't know if they're high risk or not based on all their other numbers, that this is a test you can actually get now through your insurance company. Most insurance companies are covering it. So it's something you can even teach your own physicians about if they don't know about it. So please check out our website. We're constantly updating it. We have a lot of health tips and we have blogs. We actually show all the publications we've written from the study, but we make this information more easy to understand with some of the blogs that we write. I want to thank all of the participants in our study. We have 1,164, and you can definitely reach out to me. I do want to stop with sharing one more thing, and that is the most important thing you can do and your friends and family can do is get involved in research studies in the United States. We do not have enough information about how we can prevent disease, how we can prevent things that happen with aging, because we don't have representation in these studies, and not everything that happens or is true for whites will apply to South Asians. And so we're building a registry of Asian Americans, Pacific Islanders, because they are very underrepresented in studies. And it's called the CARE Registry. This is the website. And any Asian American can sign up. And this is just a way of being in a database. So if there are studies in the future, we can let you know and you can decide if you want to participate or not. So I really encourage you to join the registry so we have information and we can let you know in the future if there's other studies that may be interesting to you to join. You get $10 just for registering. So with that, I'm going to stop. And Nirmalji, I'm happy to take any questions. I'll stop
Sure.
sharing my
Yeah,
screen.
that'd be great, and then we can. So thank you. Very informative. Informative as always. And a couple of Oops, I did something here. Hang on. Let's see. Okay, there we go. So it's, first of all, the chat line is open. So if there are any questions, please do post them there. One of the questions that was already up there was when you were beginning to make some comparisons between the different groups. One of the participants had asked about did you take genetic factors into account? So you might want to comment on that.
Yeah, so we are right now, we're actually in the process of doing genomic studies in Masala. We have gotten consent from our participants. Over 1,000 people have consented for us to do that. So we're going to be doing not sequencing, but genotyping of the DNA. And we're using actually a method that includes South Asians mostly because there's rare variants that may be true in South Asians that you won't find if you use the same genotyping methods used in whites or blacks or other people. So we're just about to do that this year, and we'll be able to actually compare, differences in genetic risk for these diseases between South Asians and all. But in the studies that have been done from the UK primarily, there's no one reason that South Asians have more diabetes. There's no one gene or one mutation in a gene that can, it's going to be very complicated. So there's going to be some genetic risk, but what we know from other studies is that the genetic risk is something you're born with, and it's not going to mean that you can't change that risk. So, definitely things are modifiable with all the things I mentioned with diet, exercise, etc.
That's great. The other one that we deal with when we and this applies to any community, but in the context of Asian Indians, this is perhaps even more relevant. I think one part of behavior change is having, for the better, is having the knowledge that there is a risk associated with it, similar to a smoker knowing that smoking causes lung cancer,
Mhm.
which, talks such as yours, all of the things we do for community education and so on, uh, go after. That's one critical starting point to make people aware of what their risks are. And then, however, what I find is that then having people to make the effort to change and effective strategies in behavior modification. Have you, in your cohorts, have you begun to look at that? What causes people to act the way they act? And it's not good, bad, or indifferent. It's just, and that happens in any community. It's just that in our context, I think it would be very beneficial in the face of you know knowledge to the contrary, people still indulge in behaviors that are perhaps high risk when it comes to diet or exercise.
Yeah, no, I know. And this is the critical question is what are the ways that what are the influencing factors that make people change? And what we found really is that it's your adult children. So if you're lucky enough to have children who are adopting some of the healthy behaviors living in the US, then I think that's what makes parents change is they see, oh, my kids are doing it. And then those kids are a little pushy saying, mom, you should walk more. Mom, you should exercise more. Or you should don't eat this crap, mom. Those are these are, I think, the reasons that I think we're starting to see that people who are bicultural, who adopt some of these behaviors are doing better.
Do die, and this will begin to get into next, when we get into the next talk, which, by the way, for those of you who logged in a little later, that I have posted, and I'm doing that again, to post, um, whoops, I'll post it in just a minute again, but it's on the chat line, which is the link to register to the next conference on March 24th by Dr. Ashwini Wagle on diet, Asian Indian diets. She works closely with Dr. Kanaya, and I think will have unique insights, into that. So with diet interventions, um, what kind of advice, when you give people, other than just at the bedside, what kind of specific advice um, do you give people when it comes to diet, in terms of practical advice to be able to change?
Yeah. Yeah, no, I think the thing to know is, we all have comfort foods. We have the foods that we grew up eating. We have the foods that are, kind of like the festival foods, the ones that we really, like, that are, treats, whether it be barfi or some sort of, chevra or whatever, something that you really, feel like means something to you. And I think when we, not in the pandemic, but when we are social animals and when we get chances to meet and, go to cultural activities, go to other religious functions, weddings, all these get-togethers, that these foods are in abundance and we are getting exposed to them a lot more frequently. And that's not how our parents or grandparents used to eat in India or wherever we came from. That these were, festival foods that we ate, once or twice a week or a month, and they were special. And now we're eating them 6, 7 times a week, and that's not doing us any service. So I think for me, I mean, I went to a close friend's mother's funeral with just a small group of family this weekend, and there were a lot of treats there, and I was shocked to see how many sweets people are eating, maybe because of the pandemic and we've been shut out from doing this. But it's like just having the awareness that, this is not meant to be eaten every single day, that I can have, one gulab jamun today, but I can't have it tomorrow, and I can't have it day after tomorrow, and I can't, once a week is my limit. Those kind of, practical messages, and you have to be aware, and, that takes
So
some. Mhm.
thank you. That's good insight. And two other questions. One of them is is a little bit of a clinical history. I'm 64, female, early menopause, high blood pressure, diabetes, um, um, family history. So pretty much a lot of risk factors is the bottom line. How do I convince my physician to order preventive diagnostic tests on me, right? Uh,
Yeah.
to, and CAC is an example of
CAC
that.
is one.
Uh,
Yeah,
it,
so CAC is useful because it tells you not only, if your CAC is high and now you have normative data in South Asians, you can look at what we have in our nomogram showing what a woman of this age has in terms of average numbers of CAC. If your CAC is higher or lower, it's important information because if it's higher, you need to intensify what you're doing with your cholesterol management, perhaps being on a baby aspirin every day so that if you are along that path to developing heart disease, that if the plaque were to rupture, that the platelets won't be as sticky because you're going to be on aspirin. But if your CAC is low, then you don't need to be on aspirin. And because aspirin does have side effects that can be not so great, like, causing bleeding of the stomach. So it helps both intensifying control over risk factors, maybe adding new medications, but also maybe taking away if your CAC is normal or zero being the best or very low. So I do think, and CAC is now covered by a majority of insurance companies. I just got it covered for a patient with Anthem Blue Cross. They were like the big holdouts, but Medicare has been covering it, CAC, for almost a decade. But now many insurance companies are covering it, and
So
it's
Mala,
not
if you,
expensive.
yeah, Mala, if you didn't get that, CAC stands for coronary artery calcium, and it's a the one that you do for screening is a non-invasive test.
It's non-invasive, 5 minutes,
Yeah,
no IV,
essentially
nothing.
non-invasive. You're able to, it's particularly reassuring, as Dr. Kanaya said, if your CAC score is low or normal or absent, there's very little calcium or no calcium. It's tremendously reassuring, because that's the ultimate final common path of what you see there is sort of the proof of what's happening. So I think that's something to consider. The other advice I typically give people, our patients do that all the time with us. Well-informed patients come equipped with information. I would go equipped with information. Sometimes it's an article. I'm happy to, Dr. Kanaya will be happy to share articles that are published information in Asian Indians. Many physicians simply, I used to be asked this question all the time as an infectious disease doctor, that many people in this country did not have a good sense of travel medicine or tropical diseases and so on. And I would frequently tell people to go equipped with the information, because that's how you get better care. You are your own best advocate. So in that sense, something to think about. One other question that's from one of the participants is, on a low carb diet, your thoughts about a low carb diet as it relates obviously to cardiac disease in Asian Indians.
Yeah, no, I think a low carb diet makes a lot of sense, especially if you're pre-diabetic or diabetic, for sure. But then if you go on a low carb diet, you have to be careful about the fat intake as well. And so, high protein and low fat and low carb is ideal, and having the protein come from plant-based foods. That's where it gets super tricky, because a lot of the carbs we eat, and Ashwini will go into details, she's actually developed a carb counting tool for Indian foods, and it's on our website in that health tips I told you about,
Mhm.
and it's by Ashwini Wagle. And it basically, if you're diabetic and you're counting your carbs, you need to know how many carbs are in mung dal, how many carbs are in tur dal, how many carbs are in chana dal. We have hundreds of dals, right? But they're not all the same in terms of how many carb each one has. And so she's developed this tool looking at each the types of diets we eat, that you can really know, because you want to choose the plant-based carbs that are higher in protein and lower in the unhealthy carb group. So chana dal being the best in the highest protein category. It takes the longest to cook because it has so much protein, right? And so, and the dals that cook very quickly are the ones with a lot of carbs and less protein. So that's a
I
nice
have a
tip.
quick question, Dr. Kanaya, on that. And in your masala study, did you actually look at the timing of food? Because as you know, Asians typically
Yeah.
they're more night eaters, late night eating, especially the dinner is always late till 7, 8, 9 o'clock many times. Did
Yes.
your study actually, and I know that most of the study, I've looked at 100 studies on diets and diabetes and obesity, but that's my passion. And I have found that even with intermittent fasting, people who fasted from 12 to 6 or 11 to 6 or 12 to 7 did better than people who fasted from 2 to 10. Like late
Yes.
night meals were not healthy for even an
Exactly.
intermittent fasting
We
and
didn't
high
look
risk
at
diabetes.
this
So
in
did you
masala,
study?
but it's definitely something that, yeah, we did not look at this in masala, but there's definitely good data showing that there's a correlation with eating earlier in the day, having less risk on health. And the later you eat, the less time you have to digest or to burn those calories. And so they go into these fat stores, which are all in the bad places, right? So doesn't it make complete sense, like intuitively, like late at night, you don't burn the calories, you go to sleep, where are you going to store those calories? In fat. And where do we store it? Unfortunately, in the liver, around the organs, in the muscle.
And I think that again is something that is illustrated by the fact that, and obviously the masala study has objectively demonstrated that, which is that we have such high risk of early mortality to or early development of cardiac disease and higher mortality. So
Yeah.
I think that that is again a wake up call for many to make sure that lifestyle changes are made, because that's the only way longer term, I guess.
Yeah. Yeah.
Yeah, and very interestingly, some people, despite having the risk, to your point, will not develop it, and I think
Right.
it's good to know that as well, right? I
Yeah.
mean, through a
Yeah.
CAC score or through whatever other
Exactly.
measures,
Exactly.
kind of good to know that.
Exactly. Yeah, so what we've done, actually, I didn't show you any of this data, is we've looked at the subtypes of diabetes in Masala, because 250 participants have diabetes, right? But not all diabetes is the same. And there are types of diabetes that are higher risk in that people develop kidney disease and heart disease earlier. And there's types of diabetes where you can, the people who get diabetes very late in life, in their 70s and 80s, those people are not going to be the ones developing heart disease and kidney disease from their diabetes. So you can actually be a little bit less aggressive in the medications you take for diabetes if you have diabetes at age 75, but you've never had it before, versus if you're 45 years old or 50 years old and you have diabetes, that's the person who's going to end up having kidney disease and heart disease and all of the complications. And they need to be aggressive about their management and control of their glucose and blood pressure and cholesterol. So there's so much heterogeneity, or like not, so there's so many differences in diabetes that not, I mean, that's the thing about personalized medicine, right? You can't treat everyone the same, especially when there's no data guiding you. In South Asians, you have to be very careful that are they putting me on the right medications, because maybe this is too strong. And there's a lot of I can give you a lot of anecdotes from Masala as well as from my own practice, where cholesterol, is a major risk factor. Cholesterol levels in Masala are not very high. Okay, LDL cholesterol is actually 110 was the average.
Oh,
That's the Indian phenotype, is not high LDL. But then when we say, oh, your CAC is high, we should put you on a statin medication to bring down your LDL. People are like, why? My LDL is not high. But the statin works in different ways, not only to bring down LDL, but it stabilizes the plaque, so the plaque can't rupture. It decreases inflammation around the plaque, so the plaque is more able to be dense and stable. So there's other ways that things may be working that maybe we're not capturing with just routine cholesterol tests, and some medications may work. And the point about statin is, I have a lot of patients who are South Asian, and usually we need to get people on pretty high doses of statins to bring their cholesterol down, but most Asian Indians actually need very low levels of statins. And not all, I'd say 90% can actually have really good benefits with even low levels of statins. And they may not need 80 milligrams as what has been shown in whites, in primarily white studies. But until we have good data that includes South Asians, it's really hard to make guidelines for South
yep,
Asian.
yep. And I think the one other question or a comment I had from I think from your previous talk, you had made a mention of this. And you might want to elaborate on that just a little bit. Is the heterogeneity within the Indian community,
Mm-hmm.
of South Indian communities,
So the
Gujarati
heterogeneity.
communities,
Yes.
um, and
Yes.
and so um, did you? I know you folks have looked at some
Yes.
elements of that, particularly related to food. Can you elaborate on that a little bit in terms of risk
Yes.
and
Right.
observations, I guess?
Yeah, so what we've done is we've actually, looked, we don't have enough numbers by states to do like Gujarat versus Punjab versus Tamil Nadu. And I wish we had, hundreds of people from each state. We have some states with more people. We have a lot more Gujaratis and Punjabis. That's just immigration patterns, right, to
Mhm.
the US. But what we've done is we've looked at North Indians versus South Indians versus Pakistanis versus Bangladeshis. So we have very few Bangladeshis, so it's not a good comparison, but at least we have good numbers of Pakistanis, North Indians, and South Indians. And we wanted to see like who has higher blood pressure, who has higher diabetes, is there differences in, X, Y, and Z. And when we look at it all together, there's actually no difference.
Mm.
There's just as much diabetes in South Indians as there is in North Indians as there is in Pakistanis. There's just as much high blood pressure. Some regions may have slightly higher, but when you adjust for age differences and other things, there's no difference. So I think we have a lot more similarities than differences when it comes to our risk. But even though our diets may be vastly different, there may be more meat eating, more fish eating, depending on the states that you grew up in or come from. There may be more vegetarianism in certain states like Gujarat, and in South India, it's a lot of vegetarianism, but also a lot of very, very high carb diets. So there may be different reasons why people are developing these diseases, but the rates seem to be just as high.
Yep. Yep. Um, are there any other questions? If there are, please go ahead and post them. I just want to make sure that we're able to ask those questions